We're going to have a panel session now. So we've invited representatives from various hospitals that are part of the implementation phase of this project. So I'm going to ask them to come forward. Lee Road from Goulburn Valley Health Service, Anita Morris from Western Health. I'll introduce you all again in a sec, but we've got Royal Children's Hospital, Bernadette O'Connor and Sarah Connolly, Danny Stone from Wimmera Health, East Wimmera Health Service, Sharon and Monique from Bendigo, and Katie and Michelle from the Women's. So please take your seats. This is going to be a bit of a challenge for me, but we'll see how we go. So I'm going to ask you to put your hand up so everyone knows who you are. I'll just go through again. Lee, thank you, and Anita, thank you, and Bernadette, and Sarah, sitting together, that's helpful. Danny, it's up the end. Sharon and Monique from Bendigo, thank you, and Katie and Michelle from the Women's. Michelle, you've met, and Kathy, beg your pardon, and Kathy starred in our video earlier as well. Okay, I think, is that correct? Yes, excellent. I could only sort of see it out of the corner of my eye. I thought that was you. Okay, so I'm going to just start with some questions and ask people to give a little bit of information to you about their experiences as part of these demonstration hospitals. We're going to start with Danny, and I'm not sure how we're going to go with microphones. We're just going to share, are we, across? Yeah. Okay, so we're going to ask Danny from East Wimmera just to tell us a little bit about the benefits and challenges of implementing the project in a regional or rural setting.
Hello.
Yep,
Yes.
just hold it up nice and close, that's good.
Good, I struggle with microphones. So from an East Wimmera Health Service perspective, we are a small rural health service. We've got 400 staff or thereabouts, 5 campuses spread quite geographically apart. Our biggest distance is an hour from one campus to another. And so when we come into the project, we were quite delighted to be asked. Then we saw the data and went, oh, that's really bad. The reason that we were asked is because our data was really quite poor. And so we've taken a very unique approach, being a small rural health service, and really looked at it from an entire health service perspective. And we've talked about that a little bit throughout the day, but we've taken it as in everyone within the health service is going to be involved. Not just our clinical staff, everyone. So we've got our maintenance staff through to our clinical staff being involved. And the question can be asked, well, why would you include those people? Our staff are key leaders within the community, and so in total population we're talking about 10,000 people, and so we have about 4% employed with us. So we've got quite an educated workforce and leaders within the community. So we were very keen on educating absolutely everyone within our health service so they can take that information out into the community and spread the news. And so Peter spoke about the football clubs. Getting that information into the football clubs, to the hockey clubs, to the netball clubs, to the tennis clubs, all of those clubs that actually exist within our health service. So we've started that by getting out and about and actually going to each of our campuses, speaking with all of our staff, or a large portion of our staff, and getting that news out there. What's been really interesting is it's been giving us the capacity to gauge the culture and gauge the acceptance of having that conversation. And this is building on work that we've already done with occupational violence, which has been very well supported within health over the last little while. And so what we've found is the staff are very keen to come on board. And so now, as we've established that conversation, and now we're going to build upon that conversation and actually get out and start rolling the project out. We've just appointed our champions, and so we'll continue to move through that. But we're very much early days.
Good on you, Danny. Thanks very much. And so you're focused on partnerships and engagement with community. Yep, fantastic. Let's go to Lee from Goulburn Valley, and perhaps you can just tell us some of the challenges that you've experienced at your hospital, Lee.
Goulburn Valley Health is a regional public health service, so about 120,000 catchment population, 2,400 staff. So the staff represent about 2% of the population that we serve, and as been highlighted before, you know, just from knowing the numbers, that some of our staff will have experienced violence as well. I think while all the challenges that I think Sue listed that came out in the Royal Commission applied pretty much to any health service, the kind of challenges on top of that, when you're working in a rural community, chances are people know people, and so, you know, the impact of family violence isn't just for that woman at that time, it can be for the staff members attending to her, the family members that surround her. So the way we've approached the project at Goulburn Valley Health is to really make sure that we start with our implementation team, ensuring that the implementation team itself is a safe environment for the people participating in the project, and that we really support them, because they're the ones that are going to be hearing those stories out in the broader community of our health service. So where we're at with the project, we've taken our job very seriously as being a demonstration project for the toolkit. So our first task was to make sure everybody on our implementation team read the guidelines, read the toolkit. And we're focusing just on the first 2 elements of the 6 elements, given the timeframes for participation in this project. So we're really just looking at the, I forget what the first one's called, but I think it's the engagement and the governance commitment. And the second is looking at culture. So the kind of things that we've tested are, how do you introduce this concept to your executive team? So we've done presentations to the exec team, to the broader staff groups, just to raise their awareness of the project, that we're participating in it. For some, it wasn't a surprise. It's flagged in our statement of priorities that this is what we will do. And we'd probably been trying to make sure that when we started this project, it was fertile ground. So we'd started some chatter around White Ribbon Day, the launch of the Daisy app, raising people's awareness of the 1800-RESPECT website, the Champions for Change, as much as we possibly could through our informal networks before we started a formal process.
Good. Thank you, Lee, very much. Let's hear from Anita. Anita's at Western Health, which obviously has a geographically large and really diverse community. So tell us how you're going there.
So we have just over 6,000 staff across, we have a catchment area of 8 local council areas. And with that, we have quite a culturally and also socio-demographically diverse area. And similarly, our community are also represented in our staff group. So our staff group make up the largest employer in our area. And with that, I guess it's important for us to take time to think about how do you educate or train that many people to be able to change the response to our victims, survivors that come into the service, but also how does that then feed out into how our community understands that we're responding. We've certainly started from a governance perspective, and we've appointed our Exec Director of Nursing and Midwifery as the exec sponsor, and I'm working 1 day a week in a project role till the end of the financial year to roll out this toolkit, certainly not to the point of training, but to the point where we know where we're heading. And it's been great to have that support from exec in putting together a vulnerable persons committee that covers off on 3 priority areas at the moment, which is elder abuse, family violence and child safeguarding. And I think there's some nice overlaps in the work that we'll be doing to roll out initiatives in that space. So at this stage, our committee will report through to our Best Care Committee, which is our governance framework. And we're also in the first stage of rolling out our senior manager training, so sending staff along actually to the women's in the first instance, and then looking at how we can in-house that training so that our senior managers are prepared for what's ahead when their staff are trained and their staff are able to respond appropriately. So that's in a nutshell.
Thank you, Anita. That's great. Thank you. Let's go to Sharon. Sharon, I'm going to ask you a question about documenting disclosures and how you've gone about that, how you collect data. Possibly on, just try it as it is and see how you go.
Hopefully it's on. Peter Faulkner spoke earlier about the documentation that we've actually introduced at Bendigo, and as he demonstrated the lovely form that we've got in place, it's actually based, we've worked very hard to base it on the CRAF, the Common Risk Assessment and Framework, and we're very cognisant that we're not trying to make frontline staff family violence specialist staff. We're asking them to identify as much as they can, to ask those questions of staff, of patients and clients who come through the door, and giving them the form to capture as much of that information so that safety planning and appropriate referrals can be made. So we have got that in place. We've also got the IPM, which is the inpatient management system at Bendigo Health, and we've been very well placed. Bendigo Health is moving to the digitalised medical record very shortly before we head to the electronic medical record. So we've been very fortunate to get into that.
Fantastic. Okay, thank you. Let's go to Bernadette from the Children's Hospital. Perhaps, Bernadette, you can give us an overview of where the Children's is at present. Thank you.
Thank you. I suppose dealing with family violence is not a new issue at the Children's. However, I think it's fair to say that we haven't had an organisational-wide strategy or viewpoint on it. So we've been really grateful to be involved in stage 2 of the project, which has given us the capacity to appoint a very part-time project officer to just do a bit of mapping, I suppose, and working out what it means to implement a family violence response within a paediatric health setting. We already had a Vulnerable Children's Committee, and we brought this piece of work in under the Vulnerable Children's Committee, which has executive sponsorship and has representation from across all departments at the hospital. We've also very, very grateful that we were successful in getting an advanced allied health practice grant, which will enable us for the year going beyond the end of this financial year. We really hope to further develop the work and come up with, I suppose, something that we hope, our strategic aim at the hospital is to be a great children's hospital leading the way, and we're hoping that this further piece of work will allow us to have a tool, I suppose, and some opportunities for other children's hospitals to use the work that we do.
Very good. Okay, thanks. And now, Monique from Bendigo, you're a social worker and you work a day a fortnight to deliver the project, and training's a big part of your role. So can you tell us how you're going about offering training in the different sort of ways that you're looking at that?
Thank you. As the clinical champion for the women's health area, my role has been very much about providing education sessions to our midwifery and medical staff within women's health, maternity, and our child and adolescent unit. But more recently, I've had the opportunity of actually providing some of that education to our inpatient units as well. So I basically take whatever opportunity I can get. Ideally, I would like an hour to be able to provide the combined PowerPoint presentation looking at both identifying and responding to family violence, but most commonly I don't get an hour available. So 20 minutes, half an hour is usually what I get made available, and I use that opportunity to just talk freely to staff. So I don't use a PowerPoint in that space of time. It's quite often the staff handover time that I get. So I will return to a inpatient unit, one of the acute units, 3 or 4 times to try and capture as many staff as I can, and hope that then they go back and share some of that information with their fellow staff. And the idea being to introduce that we do have a policy at Bendigo Health to identify and respond to family violence. I talk about documentation. I talk about linking that policy with the vulnerable children's policy. I talk about referral pathways, and just trying to get the idea out there that all of this is very much our business as healthcare professionals, that we need to know that family violence is in our community, that we need to be asking questions, and where to seek further information if they need to.
And would you have any key tips for anyone else who's going into that education and training role? What would be your key advice to them?
I do come across a little bit of resistance sometimes, particularly in the acute inpatient areas where I do get asked, why do we need to do this? For example, it might be a surgical area where the staff feel that their speciality or their skills is around dealing with, post-op surgical patients. Why do they need to be dealing with family violence? So you have to appeal to their sense of responsibility and care for our community. And as it has been mentioned before, talking about not trying to turn everybody into a social worker or a family violence practitioner, but being able to identify, know how to have those conversations, and being very clear around pathways. I think if staff know that there are clear pathways, which we do have at Bendigo Health, it's a much more encouraging reason to be asking the questions than to be feeling like you're going to ask questions and have nowhere to go. So that reassurance is really important.
Fantastic. Thanks, Monique. Now we're going to go back to Anita. Anita has also completed a PhD on children's voices in family violence, and we saw the video this morning with the children, which is obviously a really critical part of this project. So I just wondered whether Anita could give us a little bit more information about the work that you've done around children's voices and how we can increase the voice of the child in this work.
Thank you. I think if you take a look at the toolkit, it's great to see such a focus on responses to women experiencing family violence. But what I find, and I'm particularly looking for responses to children when I'm looking at documentation, is very often there's an "and" in front of the word children. And that's really disappointing because it doesn't mean that we're considering children as victim survivors in their own right, which means that the way we design our models of care doesn't take into an account a direct response to a child, not necessarily children that come along with their mother, but a direct response to the individual child. So I think there is thought and consideration being given in the second version of the toolkit to where do we need to go to make sure that each child who comes into our health services who's experiencing family violence does have a voice and is able to have their own needs met. Because from my research, even siblings within a family require different things of us as professionals. Not necessarily always formal responses like child protection, but certainly an opportunity to say how this violence is impacting on them. Do they feel safe? Where are the places that they feel unsafe? And if we don't give children that opportunity, we are not really having an impact, which we could be. We could be having a wonderful early intervention on that next generation of children who will, unfortunately end up as patients in our health service if we don't do something different.
Thank you very much. Let's go to Sarah from the Children's again and just get a little bit more of an input from you about your experience in that setting, Sarah.
Thank you. I think certainly I would echo everything that Anita has said. For us, the project and the toolkit will need some adaptation in terms of implementation in a paediatric environment. So as Bernadette mentioned, the grant that we have been fortunate to secure will assist with that work. I think one of the biggest issues as a paediatric healthcare provider is that children inevitably present with their parents, and where there's family violence in that parental relationship, then the opportunity to in fact assess, we heard earlier about the importance of confidential space, and so an opportunity to assess that is extremely difficult, and one of the major practical challenges is where to start when you have mother and father and child in the room, and how do you actually create a safe space to have those conversations for the victim, generally the mother, not always. Another major challenge, I guess, then is around documentation, because again, the child is our patient, so it's the child's health record that we document in. Particularly for the children's, we've just launched our fully integrated electronic medical record at the end of April. So, and with technology, parents have access to that through an app on their smartphone. So how do you ensure that information is sensitively and appropriately recorded, but not, to place the victims at further risk? We know that children living with family violence are more frequent attenders at emergency departments and health services generally. So really requiring quite a lot of work for us in terms of culture change across the organisation to really consider that family violence is front and centre of the work that we do, and as Anita said, not an add-on.
And Sarah, have you managed to get strategies in place to deal with that confidentiality issue?
So that's a big piece of work that we're looking at the moment.
You're in progress at the moment, yeah, good, okay. Thank you for that. Let's go to Kathy from the Women. So, Kathy, we just want to ask you a question about change management, and I think it's already been mentioned on the panel that there is sometimes resistance to change, and just wondering, in your work, you're in the Women's Emergency Centre, how you have addressed resistance to change?
I'm a registered midwife working on the floor in the emergency department, and I've taken on the role of promoting and supporting strengthening hospitals' responses to family violence. And what I found is that historically emergency departments dealt with injuries and quick treatments, and that the staff that's exactly how the staff still sees the caring of patients. So I've had to use a lot of techniques to try and break down resistance to change, and I think that what the Strengthening Responses project has shown us is that we now know family violence victims present to the ED for multiple issues, and they present multiple times, and a lot of these things are UTIs, miscarriages, STDs, pelvic pain, chronic pain, insignificant pain, and so when women are presenting with these stories, we need to use our skills to look for indicators, to ask questions appropriately, to actually get a background for these women, and to, I guess, put together a file so that if they present again and again and again, we start to see a picture of what's happening in these women's lives, and then we can put into place processes to help them. We also know that 37% of women suffer domestic violence in pregnancy, and 17% suffer at the very first time. So information like this I'm using this information, or we are, whoever is promoting the Strengthening Hospitals Responses, to bring on board all the staff. And I think that for myself, it's been an eye-opening experience, and I've always seen, I think, domestic violence as being in the background of a lot of my patients, because I'm a paediatric nurse, then a registered nurse. So if it's eye-opening for me, then it's eye-opening for those who have never been looking for it before. So, I guess, we just keep working hard and moving forward, and, we make sure that we have the resources and the support people. And if I don't know the answers to questions, I make sure that I find them for the staff.
Good on you. Fantastic. Okay, we've got a few minutes just to invite questions from all of you here. So if anyone would like to ask a question of any member of the panel, or just put a general question to the panel, or make a comment about anything that you've heard this morning, just now is your opportunity. So feel free. We've got one microphone over there, and we can invite people to come forward to the microphone. Thank you. And put your question. Thank you.
Is it on?
Yes, it's on. Thank you.
I'm sorry, I don't know who to direct this to, but just a general question. I come from Long Community Hospital, and we have about 5,000 people living in our catchment area, and we have a staff of 100. We actually have 2 staff members here today, which I think is really showing a strong commitment from the hospital. But just a couple of key things that you think, as a very small hospital, stretched with resources, but very keen to do what we can. What would you suggest would be key things for us to focus on?
Key thing, maybe Danny, we could ask you to address that, just as another small health service.
As a small health service, I think for us it was really about having commitment from the senior management team, and I sit as the director of clinical and community health, so responsible for all of the clinical services within our health service, and so it was very much having that commitment at that level. And I personally went out to all 5 campuses and had that engagement with the staff to put it out there on the agenda, and it's not going away. This is a multi-generational change, and so this is going to continue on and on and on and on and on. And so as a health service, this was a start. We're going to continue to work through it, long after I'm gone. But it's something that's going to take that real long-term approach, and that was the direction that we've taken.
Good, thank you. Go ahead. Thank you. Any other questions? Would anyone else like to make a comment or ask a question? Thank you over there.
Thank you very much for your in-depth knowledge of where we are and where we're going to. But we've talked about health policy, and we've talked about how we go about implementing it. But one of the things is that a lot of my staff in the community, how do you separate the victim from the perpetrator? Because I think the majority of time we are very conscious that our staff in the community are actually very in close proximity to the perpetrator. So how do we go about educating our staff, and how do we go about implementing this policy that is robust and very, very good for any establishment? So just a general comment.
Thank you. Who would like to respond to that question? Perhaps over here, thank you. Have we got a microphone there? Yep.
Yeah, I think in particularly the rural communities, this is very ever present in people's minds. You know, the chances that you know not just the victim but the alleged offender, quite high. And that there may be people who, for a variety of reasons, may be going through really tough times. So because I have a lot of community staff that work in my directorate at Goulburn Valley Health, and they certainly, as people experience drought, dairy pricing crises and various things can place huge stresses on those communities. So I think having your staff are aware of a wide range of resources and supports available to not just the victims, but to anybody who's suffering from various stress and maybe reacting to that in certain ways, but also knowing what the legal, because, frankly, in most instances, we're talking about a crime against the person. And so being aware, your staff being aware of what the sort of reporting protocols might be or opportunities and options might be for people, as well as the help sources of help for offenders might be in your community.
Thanks, Lee. But there are obviously particular challenges in rural areas that perhaps are different to the challenges in metro areas because of those close communities.
There's some common, but yes,
Yeah.
and I suppose it's the support for your staff as well, that it can be distressing for them, and knowing that they have somebody that they can talk to for support as well is really important.
Thanks, Lee, very much. Over here, yes? Has anyone got the microphone over there? Susan's got it ready for a question. We might take one more before we break for lunch. Would anyone over here? We will take two more. Thank you. Yep, go ahead.
And just trying to understand the change in terms of culture, which you mentioned. How do you measure that you have achieved some sort of shift between the culture, and how do you maintain it?
Very good question. Has anyone got to the point of being able to measure or thinking about how you might do that? Does anyone on the panel like to make a comment? Perhaps, Michelle?
I think in terms of the clinicians that have been trained, we've been able to measure a change in their practice in terms of their confidence and capacity to identify, respond and refer. So in the Our Watch evaluation of the first stage, 90% of our staff said that their practice had improved following the training. So in terms of that change in clinical practice, we have measured that. I think another really useful thing that we're doing at the Women's is we're going for white ribbon accreditation. And as part of that process, you've got to do a baseline survey of the culture within your health service. So we've just recently got the results to that, and that's really provided us a really strong baseline that we can now work off. And by the end of this year, we'll be going for that accreditation. So I would certainly suggest one way of measuring the change in culture through that white ribbon accreditation process. We're certainly going to be able to have a good look at that.
Excellent. Have we got any hospitals that are white ribbon accredited yet? Not yet. No, Women's might be the first. Thanks, Michelle. Let's go over here.
Kerry Papakostas from Monash Health. I just wanted to ask about documentation. We ask in maternity and we document in maternity, but if we're doing it service-wide, one of our struggles has been we use a birthing outcome system and we don't document it there. We document on a hard copy record in codes, which are only therefore legible to people in maternity. So if we were to use IPM, is there some flag or an alert or something to come up to say to go look elsewhere, whether it's in medico-legal or somewhere else?
That's a question for Bendigo, I think.
Yeah, we've had a great discussion.
We might just get you to grab the mic, thanks.
We had a great deal of discussion at Bendigo around whether we actually have an alert, and we decided not to. I know that the Women's have family violence alerts in their system, but we decided against that because it does pop up in all sorts of different areas. I think with the move to the digitalised medical record and the electronic medical record, being able to find the documentation will be a lot easier. The IPM referral tab, unfortunately, is only tied to one incidence of one episode of care, so whether that be an outpatient appointment or an inpatient admission. We haven't really come got a good answer. So I'm happy to discuss it further.
Good question and work in progress in terms of thinking that one through. Okay, thank you. Now, would you like to make a comment on that too? Thanks.
I think it's interesting to hear the experience of Bendigo Health. At the Children's, we do use an alert system, which is a generic alert around a vulnerable child. We also have a number of subcategories around social issues. But what we're finding, particularly with the electronic medical record, is that will enable us to pull a whole range of reports. So, for example, where there is an alert around a vulnerable child with a subcategory of family violence, we can then measure and track children who fail to attend for outpatient appointments, or where there are other sort of psychosocial comorbidities, and try and really target our intervention with those children and families. So I'm sure it's a very complex debate with pros and cons, but that's been the experience to date for us.
Great. Okay, thank you very much. Now, I think we might wrap up at this point for lunch. So I think we've had a lot of information this morning, and it's been hopefully very informative and engaging for you. To me, the key messages we've had is we've got to call this out. It's much more prevalent than perhaps we all thought in the past, and it's time to stand up to it. The tools are going to be there and available for you, and the work that's been done in all the hospitals that are participating in the project is going to be freely shared, so you're not on your own in trying to implement your systems. There's a lot of skill and expertise now and resources to help you. We've talked about some of the challenges, the difficulties associated with privacy issues, the importance of reaching out, the difficulty identifying people. I think we heard a few times clinical training is the last step, so the importance of getting your systems in place and your governance arrangements in place and getting everything well prepared so that the clinical training is really effective. So we've had some terrific presentations, and then we've had a really well-composed panel with lots of skills and experience telling us how this is happening. So can you join with me in thanking the panel?